I'd like to talk, when you mentioned hormone replacement therapy, I'd like to talk about the birth control pill. I'd like to talk about fertility drugs. Do any of those have an effect on breast cancer?
So the data on birth control pills is really hard to ferret out because the birth control pill has undergone so many changes over time, from being high estrogen, low estrogen, implants now. So it's been very hard to sort out what the real risk of oral contraceptives are with breast cancer. But I think the data are pretty convincing that there is a very, very slight increased risk of breast cancer in women who take oral contraceptives. So I think that's the current thought, yeah.
And fertility drugs?
But the fertility drugs have been harder to sort out. The fertility drugs unquestionably have a higher incidence of cancer of the ovary, and there is some suggestion that they may have a higher incidence of breast cancer, but I think we don't have enough data yet.
Yeah,
the jury's still out on that.
The jury's still out, yeah.
Okay. What advice would you give a newly diagnosed breast cancer patient? Someone says, oh, well, I have a cousin that was diagnosed and is being seen at whatever hospital, and they don't have access maybe to a comprehensive cancer center, or they're shy about, or whatever, getting a second opinion, or, what sort of advice would you give to somebody that doesn't live near, a University of Michigan, a city of hope?
So breast cancer is so common nowadays that there are, even in places that aren't close to a comprehensive cancer center, people who specialize in the treatment of breast cancer or whose practices predominantly have patients with breast cancer. So I think if you can be seen by someone who specializes in the disease, I think that's beneficial. And there is a whole network out there through the American Society of Clinical Oncology, through the American Cancer Society, where you can really get help in trying to find a specialist. So to really reach out to national organizations as well. And to know you're not alone. There's a large community of people that really want to help patients with breast cancer. So to search, and that you are your best advocate in finding the right provider for you. And a second opinion is fine. It's a really, it's a life-changing diagnosis for many, and it's fine to seek a second opinion. And I don't think your doctor will have a
That's the big thing. It's like, I don't want my doctor their feelings to be heard, blah blah blah.
We encourage a lot of patients to see second opinions, and I think the reason being sometimes it helps to hear something again. A lot of times the second opinion is just confirming what one other person would do. It's not very often that we will have a different opinion, but I do think it helps a lot. It helps patients, and I encourage my patients.
So what are some of the new therapies that are exciting that are out there?
Let me start about cryoablation. Yeah.
Well, there are some newer surgical techniques. For smaller tumors and for patients who qualify, they can have their tumor frozen rather than taken out in surgery. There are newer techniques, I guess, in the operating room where you can have radiation at the same time as your surgery and not have to go through the full 6 weeks after surgery getting radiation. Again, for the patients that do qualify for that. I'm trying to think of other...
Well, we do a lot of, I mentioned before, nipple sparing mastectomies, which I now think is pretty common, and then I find out it's actually very geographical, so in other areas of the United States it's not as well embraced. And I think part of it is we have great access to plastic surgeons, but it's preserving the whole appearance of the breast, so actually when a patient wakes up, it will look like nothing's changed. So I think that's important. We can do these procedures with targeted X-ray dissection, so we're taking out less lymph nodes for patients, which even if they had a positive node prior to chemo, so I think that is decreasing the chance of lymphedema and arm swelling, so it's better for the patient.
So, overall, with surgery, I think we're trying to get the patient back to their baseline as quickly as possible. So we're trying to minimize how invasive we are with our procedures as a whole.
When we were talking before about men with breast cancer, one thing I forgot to ask is, what's the treatment for? Is it the same chemotherapy and nothing's changed? I mean, it's not different because it's a guy versus...
Yeah, interestingly, it's pretty much the same. The surgeons need to...
the surgery is different, but...
Okay.
They really only have one choice. And that's a mastectomy. We haven't quite started doing lumpectomies with radiation, but...
Then the rest of their treatment is exactly what we do in women. The same hormones that we use in women, we use in men, because most of the time their cancers are actually fed by estrogens.
Interesting.
So,
yeah. And then what about in women that are premenopausal? How do you counsel them as far as fertility issues if they haven't had a child yet? Do you suggest that they freeze their eggs?
yes.
We refer them to a specialist.
Yeah.
Yeah.
I mean, there's so many. So, what used to be the Lance Armstrong Foundation, what's it called now? Livestrong. So there's so many support systems for young women who, still want to have children who didn't. It's very expensive to freeze your ovaries, to freeze your eggs rather, and so foundations like Livestrong will actually pay for the majority of the medications that actually lead up to having the egg harvesting. Now, they won't pay for freezing the eggs and keeping them in however long you're going to keep them for, but they will actually pay for all the medications that are required to harvest the eggs. And one of the things that people always worry about is, well, you're stimulating these eggs. Are these hormones that we give people, are they going to stimulate the breast cancer? And it turns out that a lot of the hormones we use to stimulate the eggs actually are drugs we use to treat breast cancer. So there's not a real harm in doing that. It does delay starting treatment for 3 to 5 weeks. But if this is an important issue for an individual, it really is the ideal opportunity to store your eggs before potentially chemotherapy might render you into menopause, and so you don't want to miss an opportunity early on. And again, this goes back to the fact that most women who are diagnosed with early stage breast cancer don't die of breast cancer, so quality of life is incredibly important, and part of that quality of life is obviously fertility.
Just out of curiosity, how much is it? I mean, what is a procedure, or the medication and then freezing your eggs? What would you ballpark?
It's like 12 to 16,000, I think, is what it is usually.
That probably sounds about right. I think that people need to be, this wasn't something I thought about, but then it costs a lot to actually bank those eggs and store them for many, many years. And I think that's something that some people aren't aware of.
So what would you say about prevention? So what would you tell someone who, let's say, is a postmenopausal woman, and would you give her advice about her daughters, her nieces? I mean, what would you say about prevention? Is there prevention for breast cancer, aside from what we talked about with hormone replacement therapy, you know what I mean, or the birth control pill or whatever? What else can a woman do to avoid having to deal with that?
Well, the main thing would be exercise. So that's been shown in multiple studies. So regular, consistent exercise does decrease the chance of developing breast cancer. And it has to be, it can be just walking, but it does need to be consistent, about 5 times a week, about 40 minutes a session. It needs to be cardiovascular. So unfortunately, yoga and Pilates don't necessarily count.
I didn't know that.
Yeah.
That's very interesting.
Yeah, so they might help reduce stress, but we actually, and we don't know what the process is for why exercise decreases the chance of developing breast cancer. Maybe it's boosting the immune system, it's releasing endorphins, but it's been shown in multiple studies. So that's why I always tell my patients when they ask, well, what can I do to, for my daughters, what can I tell my friends? So I say, consistent exercise.
That's fascinating. I didn't know that. I didn't know that the cardiovascular issue is tied to that.
Obesity is another huge component of this. And I think, if somebody ever questioned that obesity was an issue as a breast cancer prevention issue, there are studies now that show that women who've had bypass surgeries for obesity actually have a lower risk of breast cancer. And so, maybe it has something to do with the surgery, but maybe it has to do with the weight issue. Fat is very metabolically active, and how it makes breast cancers grow, we don't know. But clearly obesity is a risk factor for breast cancer, and knowing that women who have bypass surgeries have less breast cancer make you realize that weight really is an important component of breast cancer growth, and presumably controlling your weight will prevent you from getting breast cancer as well.
Well, hasn't obesity replaced tobacco use as a number one
Is that right? Yeah,
cause? I mean, or at least I read that somewhere.
Yeah.
Well, it just goes to show a healthy lifestyle, I think, is important not only for cancer, for heart disease. It's the number one thing that we should be counseling our patients about, and our women friends, is just the importance of maintaining an adequate body weight and exercise. And then for those patients who are at high risk, there also are medications that can be used to decrease the risk of breast cancer. So if someone has a very strong family history, that could be they could see someone from genetics who could talk about whether or not they would be a candidate for that. But I'd say lifestyle is number 1, 2, and 3.
But surgery is also an option.
Right.
Yeah.
So let's talk about BRCA 1 and 2.
I think there's a much more awareness now about genetic mutations, and certainly I think when Angelina Jolie came out and talked about her diagnosis, that a lot of people then started asking, is there a risk of me being a genetic mutation carrier? So it really is out there. But also when the one company, and I forget their name, lost their patent for on the genetic mutation on BRCA1 and 2, then a lot of other companies came out, and they are doing now large panel testing, and I think that's bringing the cost down. So it's more available to women. So we look at family histories. We send a lot of people. We have genetic counselors at City of Hope. So family history, paternal, maternal. Some people forget it can be passed on the dad's side. Any woman under the age of 45 who presents with a breast cancer, automatically we send for genetic testing. But we will see a lot of patients who don't have a cancer diagnosis and know that they're a genetic mutation carrier, and so they will come for prophylactic surgeries. So Dr. Jones can talk about those.
So, yeah, if someone has a genetic mutation or is a BRCA1 or 2 carrier, they don't have to have surgery to remove both of their breasts, so they certainly can. There are other ways they can enhance their screening or help prevent breast cancer, so they don't have to have their breasts removed, but that is an option.
Okay.
And if they do decide to have their breasts removed, we can do either what's called a skin-sparing mastectomy or a nipple-sparing mastectomy, where the skin is left behind, sometimes the nipple is left behind, and we can do reconstruction at the same time. So as Dr. Cooper stated earlier, if they, when they wake up, they see
themselves whole.
Yeah, exactly.
Yeah.
Exactly.
Instead of how women used to be mutilated, or whatever. Well, I use that word, but years and years ago.
Yeah.
So do you ever recommend that if you have the gene, what do you advise them as far as their ovaries? I mean, does that ever...
So that's actually a bigger risk, only because it's 20% for a BRCA2 carrier, 40% for a BRCA1 carrier. We don't have good screening modalities for ovarian cancer. So that's actually the most important one to take care of first, because it is lethal in a lot of cases. So, and can be silent. So we recommend that. And actually, if you have the ovaries removed prophylactically before the age of 35, it actually protects the patient from developing breast cancer. So that's something that we talk to our patients about. But there are issues with removing the ovaries at a young age. And one of them is bone loss. And so that is also something that our long-term survivors have to deal with. So don't know.
You want to segue into the survivors?
Survivors, okay.
Yeah, let's talk about that before we go into the side effect.
Yes.
Okay.
So I keep saying that most women who have an early stage breast cancer don't die of breast cancer. But certainly the treatments that we use, the chemotherapy and the hormonal treatments that we use to treat breast cancer, do have their side effects. And for young women, I'll let Arthi hurry talk about the older women then. So in the young women, the biggest complication of giving chemotherapy is that we put people into menopause. And it's really a critical issue to realize that, because basically we take young women and we put them into menopause and made them older women. And so you have to worry about issues like osteoporosis, loss of bone density. Even though they may be 40, because their ovaries are no longer functioning, they may be at risk of bone loss, of heart disease. And so those are sorts of things that most primary care docs may not be attentive to, because they're more worried about breast cancer recurrence in young women. And so, but really the issues are more important about maintaining normal health, and we need to make sure that we check the lipids once a year. We need to make sure that your bone density is checked, because if it's low, we want to address it before there's a fracture. And so those sorts of things are really critical in survivorship. Those are the long-term effects. Short-term, we become increasingly more proactive about harvesting eggs in young women, using ice caps on women during chemotherapy so they don't lose their hair. And these are also components of the survivorship issue, because this way they have a higher quality of life and are able to live a more normal existence without people knowing that they've had breast cancer and had chemo.
But when you bring up the ice caps, I mean, that's something, talk about that. I thought that was...
Yeah, ice caps have undergone a lot of iterations over the years. In 1989, the FDA actually outlawed using ice caps, because the way that these things work is you put ice on the head when people are getting chemotherapy, and that keeps the blood supply to the hair follicles from being active. It constricts down, and so the chemo can't get to the hair follicles. So in 1989, the FDA actually outlawed these procedures because there was concern that chemotherapy was not getting to the scalp, and then a cancer cell might float on up there and it could grow, and so you've not done the patient a favor by saving their hair if the cancer cells are being collecting in the scalp. So fast forward another 25, 30 years, and we actually go back to using these sorts of icing mechanisms to constrict the blood vessels to the hair follicles so you don't lose your hair. And we now have studies in breast cancer that suggest that you can do this freezing technique and people are not at increased risk of having their cancer come back. So there is a company called Dignicap, which is the first FDA-approved procedure for doing this. And it looks like a bathing cap that has little ice freezing coils on the inside. And that's a patient undergoing chemotherapy, certain types of chemo. We fit them for their cap before they get their chemotherapy. They're hooked up to a machine which cools down their scalp a half hour before they go to get their chemotherapy. They get their chemotherapy. The cap is left on for another 90 minutes afterwards, so it's not comfortable having your head frozen. But about 75% of women will keep their hair and not need a wig. So
amazing.
So older survivors.
Older survivors, so what we're trying to really understand is, how does cancer treatment impact the aging process? And in some ways, just the fact that these women have come to us and they're under our care, I think we're actually more attentive to things that might be impacting the aging process. So with that being said, as Dr. Mortimer had said, making sure that their lipids are being checked and that their cholesterol is under control. Bone health is an incredibly important issue as we age. Fractures are a major cause of morbidity in older patients, much more so than breast cancer again. And our treatments can increase the risk of fractures. So we pay very careful attention to bone health and trying to optimize a woman's bone health, both through their cancer treatment and then afterwards. And then we're studying things like what is the side effect of our cancer therapy on memory, and how is that impacting memory over time. And I don't think the verdict is out there, but it's an area that we're actively pursuing and trying to understand right now.
Interesting. And then did you want to talk about some of the side effects besides hair loss or any of that? Or no?
I think the side effects that are probably more pertinent to this group are all the side effects of the hormone agents we use. And so when young women, we put them on tamoxifen, and the side effects are mostly sort of hot flashes and night sweats, and there's a small but definite increased risk of blood clots and cancer of the uterus. But the drugs that we mostly use are the drugs in the women who are after menopause, the aromatase inhibitors, anastrozole, letrozole, and exemestane. And these drugs actually basically deplete the body of estrogen, for lack of better terminology. And so those drugs cause more bone loss, as Dr. Hurrius was talking about. So we make people older. These drugs actually can compromise your bone density and increase your risk of having a fracture, can make your lipids, your cholesterol be abnormal. But the side effect that probably is the most common with this are not the hot flashes and the bone issues, but somewhere between 30 and 50% of patients who are on these drugs get this aching in their hands and their joints. And sometimes it's tolerable. Sometimes it can be fixed by finding out that your vitamin D is low and giving you vitamin D. And sometimes it's just so darned uncomfortable that people have to stop the drug and we switch to a different hormone. And I think being aware that there are options if you have these side effects is really important, because these hormone drugs are very effective at preventing breast cancer from coming back, and as well as treating the breast cancer if it's spread. And to not be able to take the drug because of these side effects is a problem. So there are things we can do to make people more comfortable, including switching to a different drug.
Well, that's the good news. A friend of mine, recently diagnosed with cancer, was interested in complementary medicine. What are your thoughts on that?
So I actually encourage a lot of my patients to seek out complementary medicine if they're having side effects, especially things that in Western medicine we can't actually address, such as the neuropathies that people get from chemotherapy. We have certain agents that we can give them to somewhat help, but there are other things that people can seek out, such as acupuncture. One of my best friends who recently went through treatment of breast cancer and had to receive chemotherapy said that walking every day helped her. It kept up her stamina, and I think when people get chemotherapy, they just don't want to. They want to stop.
Yes.
But it is actually something that's going to help them. I do think it is the time to focus on diet and eat a little more healthy. So I actually embrace that, and I've sent people to nutritionists. So I think it's something that can work with Western medicine, so integrated medicine, looking at the whole person.
That's
So, yeah.
fabulous. Yeah. Well, I'm a believer in that, So, and there was, this is going back over 25 years ago. There was a hospital. It still exists on the big island of Hawaii, and it combined Eastern and Western medicine. So at night, patients would get healing touch, massage. They had plantings outside the windows, lavender to promote sleep and all. And I thought, you know what? It's only a win-win.
Yeah.
So, well, before we end, okay, I want to thank you all for being here, but would you like to add a few things before we end this interview? Anything to add?
My comment is always the same to my patients. Nobody cares about you more than you do. So know as much as you possibly can and
That's
be proactive.
Yeah, you have to be your own advocate. You really do.
True.
And I have to say, I feel that each and every one of us has a responsibility for our own health and well-being, and it doesn't rest on the shoulders of our physicians. They're not supposed to be taking care of us first. We take care of ourselves first, and they are helping us. But too many people don't want to take that responsibility, and they pass it off, and I don't think that's fair. And I think that they also have to do whatever they can to help themselves get the most out of their treatment. You know, if you're not exercising, if you're not eating right, and you're getting chemo, or you've had surgery or whatever, how is, you know what I'm saying? Your body's dealing with the chemo, radiation, surgery, and then you're not eating correctly, you're not resting, you're not exercising. So that's such of a workload on the human body. It's not fair. You have to do what you have to do in order to help yourself heal and make better use of modern medical treatment. I mean,
Yeah, it's a partnership between the physician and the patient, the healthcare team.
Right.
Absolutely. Yeah.
and I just want to say that 4 incredibly strong women, really, that provide hope each and every day to patients at City of Hope. And I'm so grateful for everything that you do to improve the lives of those that come to seek help and health. So thank you so much.
Thank you.
you.
Thank you so much.
Well, learn how to help yourself and help those that you love.